We're happy to have you give any suggestions of what types of themes or topics or clinical areas that you'd like us to focus on for future sessions as well. We are recording the session, so it will be available later for those of you that want to recap anything. Can I just ask you to keep your mics on mute, and if you have any questions, please do put your hand up or put your question in the chat bar. I'm going to go to Karen now. So Karen's going to give us a few updates.
Good afternoon, everyone. I've really only got one quick update to share, which is very on message because we're looking at young people and children. And we have a new service that NHC is supporting, which is called Health Spot, and it's a youth zone health offer. So basically we have a GP who will be there every Monday for a weekly session. The premise obviously is to support young people to access GP services, and if for whatever reasons they feel they don't want to go to their local GP, or perhaps they've got some specific issues that they want to have a different conversation about. Dr. Helen Jones is going to be the GP providing cover, but you can refer people in from the practices. So it will say Health Spot, and you'll be able to refer onto EMIS. So if you did have a young person who, for whatever reason, felt they wanted to have a different conversation, you could refer them to do that through the youth zone, or young people can refer themselves, and the youth zone team can also refer people in. So hopefully that service will be up and running end of April, 28th of April. And colleagues, if you feel you've got patients that would like to take advantage of that opportunity, please do refer them in, and they will be able to access just a little bit of dedicated support focused on young people. So hopefully that will be useful for colleagues. Thank you very much.
Great, thanks, Karen. So as I mentioned, we've got a children's theme. So we've got our clinical lead, Dr. Sunita Venugopal, who's just going to be giving a brief introduction about the types of things that the team are working on. And we've also got Marie Truman-Abel and Kirsten Graham, who I've not seen for some time. So it's nice to have you join us today. So Sunita, I'm not sure if Sunita is here. I can see Kirsten. Hi, Kirsten. I can see Marie.
We're here. I don't know if Sunita...
Hi. Oh, here, Sunita. Hi, Sunita. I'm going to hand over to you.
Hello, everyone. Sorry, I just logged on, just finished a clinic. So I was invited to do a quick presentation today, just to introduce myself and the wonderful team I work with at the ICB. We essentially provide and help design care for children and maternity in Newham, and there's a really good team of us, and they're all working very hard to be able to provide that. So our current work, we've been involved in quite a few projects, but because we're limited time, and we couldn't go through everything we're doing today, we thought we'd pick a few projects that we're doing. Something that we're really excited to be talking about is the Health Spot Newham. And before I actually begin, I'd like to just introduce myself. My name's Sunita Venugopal. I'm a GP working in Newham, and I think a lot of you know me. I'll just let Marie and Kirsten introduce themselves, who are part of the team as well.
Thanks, Sunita. Hi, everybody. I think some people might know me, Marie Truman-Abel. I'm the head of Startwell for Newham. And just to add, we've got a couple of other colleagues in our team who weren't able to join us today, but their details are on the slides that I'm sure will be circulated or have already. So Ellie and Kirsty as well.
Hi everyone, my name's Kirsten Graham. I'm Programme Manager for Startwell in the Newham place-based team, so working with Marie, Ellie and Kirsty.
Brilliant. I just wanted to let you know Emma Tukmachi is also on the team, a vital part of the team, and I lead both maternity and children with her, and she's a GP in Tower Hamlets, but she couldn't join us today, I'm afraid. So I'll begin again. So an exciting project that we're able to say we're doing is the Health Spot Newham. It's coming out of Stratford Youth Zone, and it's literally just come out. I think some practices have, if not all practices, have received some communication about it. It's launching in April, and it's a dedicated healthcare service for young people aged 11 to 19 and a little bit older up to the age of 25 if they've got additional needs. And it provides health checks and normal GP appointments as you would through your normal GP, and it runs on Mondays from 3:30 to 7:30 out of the Stratford Youth Zone. I think we're really proud to say we can deliver this in Newham because it allows young people to approach their general practitioner where they may not necessarily feel comfortable with their generic GP, and allows them a space that they feel comfortable to be able to discuss their health needs and concerns. So we're really excited to be able to deliver this. I think there may be some questions about how to refer into the service, and I think it's something that I would like to just bring up with NHC because there's been some questions from my practice actually. So if we could get an answer from that at some point, that would be great. That's that project. Then we've got the Hospital at Home. This is a home-based nursing support service. It's a 2-year pilot, and it's providing care for acutely unwell children. And the aim is to essentially reduce the length of stay for children in hospital. The referrals are coming from Newham and Royal London, and may well come from the emergency department, the paediatric assessment unit. So not too much for sort of GPs to be aware of, but or to be involved with, but very much to be aware of. It's had some really good results in the time it's been started. As the pilot shows, it's got really good uptake, and it's reduced 7 admissions per month. That's sort of totaling up to 62 bed days per month, which is a great cost saving, but also children are being cared for where they should be and best are, and that's at home. And then our other project that we've been involved in, which I personally have been involved in as well, is an asthma pilot that we carried out within practices working in the area, a total of 6, I believe. And it essentially was to improve the level of annual health checks that children undergo with asthma. And we were able to do this pilot after a colleague of ours and the ICB was able to secure funding through NHS England. So we're really proud of her hard work for that. Actually, Ellie, who's not with us today, but it's very valuable to the team. We've had really good results, not only from the practices that are involved that were involved in the project, but it said the practitioners, the healthcare practitioners that came from each of the practices and were ranged from pharmacists to GPs to nurses, and essentially received training from community asthma nurses, and then were shadowed within their own practices while doing those asthma checks. And there was really good feedback stating they were more confident in doing those asthma checks, and improved their knowledge. And essentially the aim is to reduce the number of children needing acute care and management of their asthma, and then, for example, reducing their presentations, admissions into hospital. So that's a really exciting project, and because we've received such good feedback from it, where we are quite positive that we'll be able to continue the work in another form with may not necessarily be a pilot, it might be embedded actually. So we need to wait and watch on that one, but really excited to be involved. So that's some of the projects that we're doing. We've also been involved in the SEND agenda. We received funding of 2.4 million for Newham for health services after including the autism diagnostic pathway and in therapies, and we've been able to reduce the autism waits from 2 years to 18 months, and we aim to reduce that further. We've got a lot of work ahead of us, and the pandemic, and for a number of reasons, meant that there was quite a lot of backlog for children with query autism and special needs. So we're really positive that we can continue to keep improving that. We had some really good and positive changes from the SEND inspection in 2024, and that's because of the waiting times being reduced, and also how we've been able to. There's been a number of new diagnostic pathways that a lot of us on the meeting are probably aware of, which means that there are now some embedded formal pathways for children, their families and GPs to access now. And also proud to say, me and Emma, we worked with the community paediatricians early on to develop learning disability training, and also promote the new CHARND service and pathway, which is the autism diagnostic service with them. So I believe that's established and working well. We've also been involved in the violence reduction pilot after receiving 3 years of funding from September 2025, and we're continuing to support children, young people and their families at risk of youth violence, and that's showing some really good impact for us in the area. And lastly, we've managed to get some work within maternity and family hubs. That this has been kind of ongoing for a while. Many of you may remember, but the maternity mate service is to essentially support vulnerable women through pregnancy, and the referrals can be made online, and it's there to provide one-to-one peer support for women in the pregnancy period, antenatally, all the way up to 3 months postpartum, and I think that's very much needed in an area like Newham. So we're really proud to be able to secure the service again. And the family hubs is something that we're still trying to secure. We've already secured it, and the family hubs we're still trying to work on how that's going to look. And perhaps Marie, Kirsten, anything I've missed? I've spoken a lot, I realise.
I don't think so. I think that's a really good summary of some of the work we've done and some of the impact.
Perfect, thank you. So I'll that's the end. This is the slide on our priorities, which has a big and wide range, but essentially some of the projects are focusing on these priorities.
Great, thank you so much, Sunita, for sharing that. And it's really good to see that all of the work that's been done and all the achievements that you've done and that are ongoing by yourself and the team. So thanks for sharing. We've got a question from Dr. Sen.
Well done, Sunita. I'm really pleased to see the music that you just blown in my eyes now about this autism services. Can you just tell me about these new autism services? Did you say something about new autism diagnostic services starting in Newham?
Oh, hi, Dr. Sen. It's already started well over a year ago. It's essentially it's a diagnostic pathway, but as we all know, rather than therapeutic, but we all know that once we can establish a child with autism, they have much more access and support, and it's the waiting times that are so difficult for children and their parents to be able to manage, and the lack of clarification. So it's very much established. There's a good website, and we did do a training session. It should be published on the NHC website, actually. I'm trying to think, but it'd be at least 12 to 18 months ago. Dr. Sharmina and Dr. Ellis, they are the two community paediatricians. They may have changed roles now, but it's still going on. And please refer. I can find the website and I suppose I'll just take a minute then to just explain that service is amazing, because as we GPs find, we do tend to get concerns from parents about suspicions of autism, but what the paediatricians are aware of is that we're not always best placed to be able to be providing that information, and getting a snapshot of a 10-minute consultation, providing that information for a referral, isn't in that child's best interest, and it's not in the service's best interest. So what the service is trying to encourage is that nurseries, schools, other forms of where the child is spending a lot of time can do these referrals, and that's why you may not be aware of it, because the referrals are coming from those areas now rather than the GPs. So it's to promote that GPs can still refer, but it's now easy to it's much more straightforward for GPs to be able to say to parents, there is this service, it's established. The service actually prefers to get information, including reports from schools and nurseries, and they can actually refer into the service. So I will find the website for you. That could be the reason why it's not as publicised within general practice.
It's already given by Kristen. Great, excellent. Is there?
There's lots of info in the chat bar, so thanks, Kirsten. And Karen's also added the eligibility criteria for the first project that you mentioned as well. With regards to your question, Sunita, with reference to the how to refer, I think it was just before you joined, Karen did put up a slide that she said that the EMIS there'll be an EMIS referral form available shortly, or in due course, for the NHS Health Spot referrals. Yeah. We've got Tammy with a question.
Thanks, Nathan, Marie and Kristen. Sorry about my voice. Just a question around comms to schools, though, because I think as GPs, we're still getting a lot of parents who are being told that they need to book with us as the GP for those onward referrals. So it would be really helpful to have a comms, have comms sent out to the schools, the local schools, that actually they are best placed to do those referrals, and because we're still using a lot of GP appointments, because schools are actively signposting parents to book with us. So it'd be great to hear the plans for that. Thank you.
Great. No, I agree, because I'm personally still getting them, but now we've got somewhere to give with confidence to parents. But yes, absolutely, I think that's something we can work on. Thank
Marie?
you.
Thank you. I was just going to come in and add a little bit on that. So in the SEND inspection that we had, and what we've heard from GPs and parents, is that there is quite a bit more we need to do on the comms element for the autism pathway. The SEND inspection particularly sort of advised us that we need to move from sort of signposting to more hand-holding people to be able to, for families and children to be able to access that service, and be much clearer about what the pre-diagnostic offer is, because we have got quite a good offer, but we need to make sure it's being taken up, because otherwise there's no point in having that available. So there is quite a big piece of work, in ELF, to run the CHAN service, are developing that. So they're reviewing all of their comms, and I think that will be over that next year, to really make sure that everybody is really clear how it works, what improvements have taken place, because there is quite a bit more work to look at streamlining the pathway further, particularly to reduce those waiting times. So I think that's a big priority for us for 25-26. So we'll make sure that we are filtering that information through to you. And I think that's something we've reflected on generally across SEND, that we've made quite a lot of improvements, but we really need to make sure that they're communicated effectively. So that again is a big area of focus for this coming year.
Thanks, Marie. Do we have any other questions for the team? No? Okay, good. Thank you all. Thank you, Sunita, Marie, Kirsten. Thanks for joining us today, and look forward to hearing more about the work that you're all doing.
Thank you. Bye.
Bye-bye.
Right,
Thank you.
So next on the agenda, we've got Emma Towston, who's a clinical lead speech and language therapist, who's going to be talking to us about early years and speech and language therapy in Newham.
Yeah, thank you. Thank you so much for having me. I also came in just at the end of that conversation, which was really helpful, because I also do a day in Chant. I only started that last week. So I do 4 days now in the early years speech and language therapy service, and I'm doing a day in Chant operationally to try to get the waiting times down, because we were very successful in early years speech and language therapy to get our waiting times down from 80 weeks, 80, down to an average of 11 weeks now from referral to treatment. So we're really happy about that. I just wanted to give you a little overview. I'm conscious that we're very strict with time, so I will try to go through this as efficiently as possible, and then I've got time for questions at the end. Have you got the slides, please? Oh, brilliant. Thank you. So just as an overview, this is probably information that most of you know already, but what we assess and support children who have difficulties with attention and listening skills, for example, shared enjoyment, social interaction and play, understanding and using language, speech. When we say speech, we mean speech sounds, and there's sometimes a little bit of inconsistency, because sometimes people use speech to mean language. When we say difficulties with speech, we mean pronunciation and speech sound difficulties. Stammering, stuttering, disfluency all means the same thing, and we also work with children who have difficulties with their voice quality. We support development of communication, whether that's through using visuals or using any sort of signing, alternative and augmentative communication systems, or spoken language. And the complex needs service work with children who have eating and drinking difficulties and complex needs. I was really interested to hear what somebody was saying about referrals from GPs, because I do all the triage for the early years speech and language therapy service, and I've noticed recently that we are getting so many more referrals from GPs than we are from health visiting, which is slightly disappointing, because I feel it's not a particularly great use of your time. And we feel that families should really, if they've got any concerns about speech and language, initially they should be accessing their health visitors, who could give general strategies about language and communication and where to go. I just feel as though your slots are much better use for people with more severe medical issues. So we accept referrals from anyone. And one of you was interestingly said that the communication isn't great because nurseries are sending parents to you to refer to us, but that's not the case. We have an open referral system, so anybody can refer to speech and language therapy. So maybe we do need to get better at communicating that to people. But I would please urge you as much as possible to signpost parents back to their health visitors if they've got concerns about their language and communication. And especially if they just present with a language delay. But if you move on to the next slide, please, I can go through this in a bit more detail. Most of the children we are having referred to us, and I'll be interested to know whether you've noticed this as well, most of the children who are being referred are presenting with social communication needs, and by that we mean they have autistic features. So it looks like they may be on the pathway to getting an autism diagnosis. We will accept children from about 1.5 years up to reception age. So the early years service works with children for language up to reception age. Any children who are reception and over will be seen by our service to schools. We will see children who are delayed with their language skills or are presenting with autistic traits. So if a family come to you and everything else seems to be developing quite normally, or there are other areas of development such as play, understanding, interaction, and they just seem to be a little bit late developing spoken language, ideally those children should be referred back to their health visitor, who can offer some universal support for developing their expressive language. If you feel that there's more going on, such as autism, social communication, dyspraxia, dyslexia, anything like that, they can be referred to us. If it's just with a language delay that they're a little bit late starting to talk, then please do ideally signpost them back to their health visitor. So the social communication children, often we see children who do have very delayed language co-occurring with social communication and interaction needs. So if we see referrals that say not speaking, if you can be as specific as possible whether you think it's more than just a language delay, that would really help with our triage service. We work with speech sounds. So when we, as I said, when we say speech, we mean sounds and philology, from around 3 years up to 11 years old. And these are children who are finding it hard to pronounce words clearly. They're not understood by others. Sometimes they're understood by their parents, but generally if they're not understood by others, maybe if they have some dyspraxic features, dysarthric features, we can also see them. Dysfluency is stammering and stuttering. Children up from about 2.5 years up to their 7th birthday, we will see them. Often, as you are aware, children do go through a normal hesitancy in their speech, normal non-fluency, we call it, when they have a bit of a language burst at around 2.5, 3. We would rather we didn't follow a wait and see. If a family is concerned that the child is stammering or stuttering, please do refer to us as early as possible. That would be great. And any voice disorders such as croaky, hoarse voice, nodules, we will see children up to 16 years old. And if they've had their voice difficulty for 3 months or more. Next slide, please. So how families are referred, as I've said, and I just want to stress it over and over again, they don't need to come to you. They don't need to come to GPs to be referred to us. Parents can be directed to our hotline. We have a parent hotline that runs every Tuesday. Some weeks we'll have a Bengali speaker, some weeks we have a Tamil speaker. It's all on our website. Who can support parents. They don't have to be known to speech therapy. They can be known to speech therapy. It's only for parents who just want some advice, or even if they're not sure whether to refer themselves to speech therapy, they can access this hotline. As I said, parents, nurseries and any other services can refer to SLT by using the universal form, which most of you do, which is great. And after children have been on the SLT pathway, we can refer on to other services, such as early notification for further support from the Language and Communication Interaction Service, from MENCAP, from area SENCOs if the children attend an independent nursery. And we can signpost to children's centres. We train a lot of children's centre staff to run groups for parents and children with language delay and language difficulties. Next slide, please. And as a result of speech and language therapy input, we see a stronger connection between parents and families. As you're aware, sometimes difficulties with attachment can present as autistic traits as well. So even if a child and parent, if you're concerned about attachment, we will still see them because we want to build that stronger connection. Parents and children engaging in joint attention. We see better understanding from parents about how their child communicates. Even if a child's coming in stimming or banging their head, they're still communicating something. So it's helping parents understand that. We will introduce AAC, alternative communication, or signing and gesture. Children become more confident communicators. They have clearer pronunciation and a much, for voice disorders, a stronger vocal quality. And we will also refer to CHARND, which is the autism pathway, to MASH if needed, and to other services that run at nurseries and children's centres called Connect With Me for parents who are finding it particularly hard to take on the strategies that we introduce to them. Okay, and I'm going to talk a little bit quicker now because I'm conscious of the time. Just as an overview of our pathway, 80% of our children that come in are presenting with social comm. So most of those parents are offered a SPACE workshop. We call it SPACE because it stands for Supporting Play and Communication Every Day. Those children will access a SPACE workshop. It's either online or face-to-face. We will then offer normally 3 one-to-one sessions with a speech and language therapist. Onward referral to, if needed, to anybody, for example, to CHARND. We will provide a programme to nursery or school, and then we offer 6 group sessions, either Jet Set, which is a group run by our speech and language therapy assistants at libraries and children's centres, or Connect With Me, which is more one-to-one, but as a carousel model. And those, as I say, they're for parents who are finding things a little bit more difficult. Speech sound children, fluency children, voice children often just get, they don't get the workshop, but they will get 6 individual sessions of therapy from us. And then just the next slide is our resources. So I know that somebody put on before about the CHARND website. If you go to the SCIPS website, you will find information all about all the therapies: speech and language therapy, occupational therapy, physio, nursing, the Child Development Centre, and there should be something from CHARND up there. And following feedback from parents, we also have a YouTube channel which gives small video clips of strategies that parents can use with their children while they're waiting to come and see us, or they're waiting for a CHARND appointment. And they're also in different languages as well for families. So those are the links there, which I'm hoping will be shared with you. And that's it. Thank you. Very happy to take, and that little logo in the bottom right is one of our new logos, which is a message we'd like to get across to everybody, that if you connect with a child and play with a child, then hopefully the child will then speak. So connect, play, say.
That's great. Thank you so much, Emma. There's a comment from Laura. So Laura's just providing some feedback about the letters that we get from the team.
Yes.
And they do tend to be quite lengthy letters, so sometimes 6 pages, 7, 8. So it might be one of the things that would be helpful to us as GPs, that if there's any actions for the GP, so they're highlighted without us having to sift through the whole letter, basically.
Our ones aren't. I specifically don't say that the speech and language therapy ones aren't that long. Our reports... Are you sure they're the speech and language therapy ones? Because if they are, then I need to have a look at that. But I didn't think that they were that long.
You know, I might have some examples, so I can share with you what I mean.
That would be great. Thank you.
You know, I think it's when you do your assessment, every area that you're looking at, there'll be like a paragraph on each area that you've looked at. And then at the end will be recommendations for carer or parent, recommendations for GP. I'll share a letter.
Are you sure that's not the CHARND one? Because we don't do assessments anymore. We just do assessment and intervention as one block. Can you, if you share it with me, then I can have a look. Because
Laura, do you have an example that you're able to share as well? I think
It
Laura's
would be great.
is going in and out, but
Yeah,
what
yeah.
we can do,
If you
we
can,
can email you a letter
that would be
so that you're
great.
able to see.
Yes, please.
Yeah?
Yes, please. Because as one of the reasons we got our waiting times down is we don't offer separate assessments now. So our assessment and intervention is all in one block. So we tend to just do a summary report at the end. But I would be interested to see. That would be great. Thank you.
Okay, good. And then I had one other question, or I had a question for you.
Yes.
You know, we have, I think all of us practices have some patients that might be living outside of Newham.
Yeah.
So if the child is outside of Newham, should we be referring them to yourselves if they're registered with us, or should we be asking them to, or signposting them to whatever's available in the area that they're living in?
Now, that's a great question. We will see children who have a GP registered in the area. So as long as they're registered with you, we will see them. So if in early years, if the GP is in borough but address is out of borough, we will still see them. If GP is out of borough but address is in the borough, we won't see them. So it has to be GP in Newham.
Okay, great.
Thank you
Thanks
for bringing that up.
And thanks for sharing that number. I wasn't aware of the hotline. So
okay, great.
I've noted down that number, and I'm going to give it to a patient today. So thank you for that.
Amazing. Thank you. Thank you.
Okay, so we've got some hands up. Imrana.
Hi, thank you, Emma, for that presentation. And it reads very well on, you know, when, as you described, it's a self-referral pathway. You know, people can access that support. But the reality is, as being a GP, so I'm the safeguarding lead with my practice, and I work quite closely with our health visitors. Is that there are so many vulnerable patients within Newham, and so many families we see that just can't access this and do fall through the net. So particularly with social communication, like the pathway as it is, as I understand, is that the family have to go through a 6-week program, which is at their local children's centre, and that's the kind of first intervention before they can be put, be forwarded onto kind of any other parts of the pathway. But something like that, again, for some families is really hard to navigate, and particularly with the social difficulties, people working shifts, people don't have headspace, big families, small homes, the reality of Newham. That in itself becomes a barrier. But there's also so many other barriers. Like I've had patients, families who don't realise that there's a delay in the child's speech because they speak multiple languages at home, and also that kind of clear pathway of, if they're under 5, go through health visitor. If it's 3 to 11, you go through school. But as I think Arpan has also mentioned, is that we have a population where actually a lot of children are homeschooling, a lot of children go outside with the kind of mainstream schools, and kind of being that proactive to look at things on the website, mainly in English, understanding the language to explain what the issues are on a hotline. Although it sounds like it's good outreach, there are a lot of patients, particularly within Newham, who won't be able to access it the way it is. So I don't know kind of what thoughts you have about kind of those patients who are being left behind in families.
Yeah, we talk about this all the time. I mean, I've been here for 28 years now, and it's a conversation that we have a lot. The initial comment that you made about parents having to go through a 6-week course at a children's centre, they don't have to. I don't like the idea of everything being linear. I don't like the idea of if you do this, you've got to do this, you've got to do this, you've got to do this. There are groups at children's centres called Little Talkers, which we advise parents to go to if the children have a language delay, and they have been trained by our speech and language therapists to run those. And often some parents just need some general strategies to support their children. We go into children's centres, so it is a bit of a battle. It is really hard, and we do try our hardest, but we do have a therapist that is partly works in children's centres as well. So she does that 2 days a week. She goes into all of the stay and play sessions and just talks to parents generally about how they're feeling about their child's communication, and she might kind of tweak the questions a little bit to try to get them to access. We go into the Magpie project as well, which is for for families, for mums in particular who are asylum seekers and refugees. We offer sessions in all the PVI, the private and voluntary independent nurseries. We go into quite a lot of nurseries as well to try to access this. We try our hardest. I mean, if you've got any other ideas of things that we can do, and I do appreciate that, you know, sometimes parents can't access the website, but if they ever want to call, and we sometimes do referrals over the phone with them, or we can book them onto our workshops because they're either face-to-face or, you know, face-to-face for parents who maybe don't have access to the internet, but we also offer virtual for parents who have difficulties with childcare, you know, so we're trying to open it. We have access to interpreters to different languages. We offer sessions in for Sylheti speaker families only. You know, we really are trying, and I welcome any ideas. So if, you know, hopefully you'll get my email address. If you do have any ideas of how we can access those more hard to reach families, then please do let me know. But I mean, ideally the health visitors are the first point of contact, and hopefully families, even if they're just going to weigh their child, can hopefully the health visitor can probe a little bit further about their child's language as well.
Brilliant. Just to come back, we have a brilliant health visitor who's very experienced as well. So yeah, we work through things. But if we have a patient that we're stuck with next time, I might just ping you an email and work through how
Absolutely.
we can do
Please
that.
do, because I've got an amazing team of speech and language therapy assistants who are worth their weight in gold, and a few of them do speak different languages as well. So they do have the time to maybe call some parents and build up a little bit of a relationship. We've also recently just done a test and learn. I don't know if many of you, I can see that you're in Woodgrange, the garden in Forest Gate, we've run a social communication group in the community garden there, which has worked absolutely brilliantly and brought some families together who can then access the garden that they never knew about. And that's been a lovely group that we're hoping to run again as well. We're trying, we really are trying, I'm sure, you know, as everybody is, but it can be quite challenging sometimes.
Right, any more questions for Emma? No, thanks Emma for joining us. And
thank you.
Karen's put the number for the hotline in the chat bar. So I'm hoping that more of us will be ringing and using that.
But it's for the parents, yeah. So please direct the parents.
Yeah, so signposting the parent to it.
Yeah, that's great. Thank you so much. Thank you for having me.
Thank you. Have a good weekend.
Bye bye.
Right. So next we've got Naseem Ahmed, who's from the private fostering team. She's going to be talking to us about the process just to raise our awareness. So Naseem, over to you.
Good afternoon, everyone. My name is Naseem Ahmed. I'm the designated private fostering lead for Newham. Some of you may have attended my previous presentations. If you have, then I don't want to bore you to death, but please excuse me. I'll try to be very brief. I have tried my very best to kind of squeeze in a lot of information within 5 slides. Thank you. I'm ever so grateful to Maggie for your support with this, and Emma Takmachi, who I'm not sure if she's here today. But thank you very much for inviting me today. So as I said, my name is Naseem Ahmed. I'm the private fostering lead. So I've put our notification details on the front sheet because of the space and on the slides and the time constraints. So here are the notification details, MASH details, the golden number, and the private fostering website details on the front sheet. Thank you. Next slide, Becky. So everybody, I'm sure, knows this beautiful little girl. 25 years on since her death, Victoria Climbié. Sadly, this was one of the most high-profile case of the death of Victoria in 2000. She was a privately fostered child, sent from the Ivory Coast by her mother for a better life in the UK. She lived with her great aunt and her partner, and sadly in 2000 she died from neglect and abuse at the hands of her carers. And her horrific death led to was actually unnoticed by a number of different professionals who were in contact with her, had sort of contact with her, had access to her information, but it was unnoticed. This led to her death, led to the public inquiry led by Lord Herbert Lamming, which led to the significant legislative framework changes underpinning private fostering, and how the local authorities have a duty, and the agencies that have contact with children, to safeguarding children who are potentially and actually residing in private fostering arrangements. So the legal framework underpinning is the key, working together to safeguarding children, the setting up of local safeguarding children since her death, the Children Act 1989 and the amendments that were made in 2004, outlining local authorities' duties, agencies' duties in promoting and safeguarding the welfare of these children residing in these arrangements. The National Minimum Standards and the Private Arrangements for Fostering Regulation 2005. These are the key documents that underpins private fostering area of work. Thank you, Maggie. I just thought it would be helpful to actually just to kind of show in relation to Victoria, the number of multiple agencies that she was in contact with. It's just unbelievable, the professional failing on this child. It is one of the saddest case actually ever known of her death. She was noted 3 local authorities, police, health services, hospitals, doctor surgeries, nurseries, so you can see the magnitude of professionals that were in contact with her. But sadly, how could we have all missed this child's death 25 years on? But there is still a need for this awareness work to be delivered amongst our private, sort of professional network to identify those children early and refer them onto local authority MASH team. Next slide, please, Maggie. So the local authority has a statutory duty under the Children's Act to promote awareness amongst all professionals who are working with children and have contact with children. Notification section 44 places duties on all agencies who are in contact with children to notify the local authority if they become aware of potentially, or if a child is already existing, living in a private fostering arrangement. So the notification requirements are set out in Regulation 1, 2 and 3. So 6 weeks if a child is about to be proposed to be placed in a private fostering arrangement and you are aware about that, obviously advising the carers to, and or the legal guardian to notify the local authorities, and that should be done before 6 weeks prior to that arrangement is to begin. Regulation 3, if an adult is wanting to place the child in a language school, for example, or boarding school, they must notify immediately to the local authority. Regulation 3, parents and legal guardians must notify immediately if they have already placed a child there. Failure to do so, it is an offence. But since I've been within my role for the last 9-10 years, I haven't seen any sort of any sort of arrest or anything. But it is a legal requirement placed on agencies and parents and legal guardians and them to do that. In Newham, we have 86,585 children and young people resident in Newham. Currently, we only have 8 privately fostering children known to our local authority. It's not a reflection of number of children that we know and have contact with. I just put some stats here just for your information. Over the last 3 years, we've only had 7 private fostering notification from health, and there is such a need for our health colleagues to be sort of more targeted work to be delivered with health colleagues to actually get these notifications up, and what exactly is actually being done at the moment on a local level to actually identify those children during GP registration forums, GP registration processes, and other work that's been done in the community. I'm grateful to Emma, who has supported me in this. I know that we are in consultation at the moment about the GP, some questions being added to the GP registration form potentially, but I am in conversation with her, and hopefully that could be something that we may be able to sort of embed, and some of the private fostering triggers to help us, sort of identify those children early on and notify them. Thank you, Maggie. Next slide. So the legal definition, what constitutes a private fostering arrangement? It's a child 16 or 18 if they have a disability, is cared by somebody who is not their parent or close relative for 28 consecutive days or more. And that is an arrangement that's made privately without the local authority involvement. We know that a lot of children may be, already known to local authority social care teams, may have, undergoing sort of child protection processes, and these arrangements may be made, subsequently, just to kind of minimize the risk and what have you. But we have to be mindful that those children will go to a different legal pathway. But those children who these arrangements have been made privately without the local authority involvement and living with non-relatives, it would constitute a private fostering arrangement. So in terms of, we need to be determining the GP registration processes, who the child is actually living with, whether they have parental responsibility or not. It is one of the key things that we should be sort of asking at the point of GP registration. Maybe that's where we are maybe missing a lot of those children potentially. And it does have a significant implication in terms of if we don't know if an adult who is caring for the child has PR or not. There's issues around consent and, health and healthcare and treatment and stuff like that. So obviously it is really, really, really important that this information is determined. And if in doubt, if you have problems sort of determining this information, do raise a flag to the safeguarding lead within your practices, who then would need to have a conversation either with MASH or myself, or email us just to kind of check out whether this would actually fall within a period. If in doubt, I would say please raise a notification to the MASH team, because we will do the verification, we will do the visit, and we will determine such information. So the close relatives, the children act, go back. The close relatives are step parents, grandparents, uncle and aunt, and siblings. So if a child is living with any of these determined adults, it's not a private fostering arrangement. The private foster carers can be a cousin, a great uncle or aunt, family friend, teacher, neighbor, pastor, a total stranger. If a child is residing in any of those non-close relative, then it will, and obviously the number of days, 28 days or more, it will definitely constitute a private fostering, and please do notify immediately. Next one, please, Maggie. So examples of children in these arrangements. So children who have been sent to the UK for a better life, children who may have been trafficked for the purpose of exploitation and residing with unknown adults upon entry to the UK, children who are brought over to the UK with a view to adoption and circumvented the immigration and inter-country processes. That is one of the concerning things, is that obviously children are brought in to the country, were either adopted or falsely adopted with false documentation. So this is an area that that we are scrutinizing during our assessment process quite rigorously, and undertaking those comprehensive assessment during that. We have had many of those children in these arrangements, and it's a lot of work, but ultimately, obviously, these children were kind of safeguarded. Homes for Ukraine, under the government issued some guidance in July 2022, unaccompanied minors who come to the UK with parents or without parents and legal guardians should be, the guidance states that those children should be assessed under private fostering framework, and those children, if they come to your practice notice and their registration, do refer those children on. There is a statutory requirement under those children that need to be referred. Children in independent and boarding schools who are residing with host families during their holiday period, those children will require to be monitored and assessed. Children in informal childminding, people make all sorts of arrangements during their, within their network, family network. But it's important to consider what is the relationship with the person who's caring for the child and determining that relationship. And if in doubt, refer those children on. Children who are living with, families, because they're not getting on, extended family members, they're not getting on with their parents or legal guardians because their parents are either hospitalized or they're not getting on with their parents. Those children, again, the legal framework, we must remember the 28 days and more, do refer those children in. Safeguarding privately fostered children, it is everybody's responsibility. These are the children who are extremely vulnerable within our community. They have nobody exercising parental responsibility for them. We often don't know who the identity of that adult is. They may claim that they are close relatives, or they may claim that they're grandparent or uncle and aunt, but how have we determined that information, and to what extent do we go to actually verify this? And then more importantly, the question of parental responsibility. Often some of these children from nursery age to 18-year-old, nobody's exercising parental responsibility that we know of. And these children have, often, sometimes, they don't have immigration status potentially in the UK. And at the age of, 18, suddenly UK border have issued a deportation order. So as a system, as agencies, we have actually failed that particular child to be safeguarded. So in terms of what can we do better, in terms of working together, we do need to be working better together, understanding, you know, sort of our curiosity around asking those very, very critical questions at the point of registration, at the point of, you know, if you are in doubt of the living arrangements of these children, and understanding the legal framework, because if we don't know the legal framework, what constitutes private, we won't be asking those questions. It is very critical. And I emphasize the question of parental responsibility here. The Lord Laming report actually made a recommendation that every child must be registered. However, if there is a question, there is a recommendation on identity and understanding the relationship of that person. So I hope the GP registration form hopefully will ask those very questions, and hope to that we can actually increase those notification from there. Thank you, Maggie. So what happens when a child is notified to the local authority by yourselves? Within 7 days, we will get a social worker to visit that child, undertake the initial checks, contact if a child has, you know, parents are living overseas, we will do our very best to actually contact the parents' legal guardians to establish what this arrangement is about, establish what the living arrangement is about, and we would do that within the 7 days. And then following that, once the PF arrangement is confirmed, we will do a 45 days single assessment, and that will detail obviously the child's needs. Obviously, we will do a DBS check and all the other agency checks that will help us actually come up with a recommendation about the suitability of the carer to care for this child. We have, following the assessment, if it's a safe and suitable assessment, we will progress that case to a private fostering team to monitor the children under Regulation 8 monitoring visits, and that's done 6 weekly in the first year of the child living in that arrangement, and 12 weekly from second year and onwards. One of the key things about the private foster, we have a 6-monthly panel that reviews all the children that are known to the local authority living in private fostering arrangements, and one of the key things that focuses in that panel process is the permanency of that child. If that child has been living in that care arrangement for more than two years, obviously our focus would be to seeking, you know, supporting that carer, maybe potentially formalizing the parental responsibility. If that is a wish of the parent and the legal guardian, that they, you know, it's not likely that the child will be returning to their home country and they will be living here for the duration of their secondary education and what have you. So that is a key area that we focus on. But it is so important that these children are notified. Next slide, please.
That's the last one. Oh.
Was it the last one? Oh,
yeah, that's the last one. Thank you.
I've done one. Wonderful. I have rushed through. I do deliver training, which is a 3-hour workshop training that I deliver with children, the looked after children service manager, and that's delivered twice a year. So that's a bit more, you know, comprehensive training workshop. So do attend if you can. Yes, please, Laura.
Thanks, Nazim.
Yeah, thank you, Maggie. I have rushed, so do fire away with any questions.
Okay, Laura? Okay, we'll come back to Laura. Tammy?
Thank you, Nassim. I put a question in the chat bar, which was, do you receive many notifications from nurseries and schools? So you've mentioned that there's 8, the whole of Newham. So is that all of us as well as schools and nurseries?
Over the last 3 years, three in 2000, and I think I've got the stats here, three, yeah. and 1 only in 2024-25. And I think, you know, a lot of, you know, I think we do need to sort of target our health colleagues to actually do what we could do together raise it.
So I think that's great that you know, that you're targeting us, and yes, we can do that with the registration. And I think from our point of view, we'll always try and check you know, when patients are coming in and being seen, whether it be for IMS or whatever else. But there is a wider piece of work here around, you know, these children are going to schools, they're going to nurseries. Absolutely. So it would be, you know, for us, it's quite nice to see if there's only 8, how many are being picked up in those other services which have much more contact with these children? Absolutely. So if we are really to learn from Victoria, and I was a Haringey child. That's where I, you know, I grew up in Haringey. So I remember this really acutely. Okay, so for me, I don't necessarily feel that it is only about focusing on health. We have to do it as a system approach, and it'd be really good when you come to these, because it's nice to know where are we picking up, and obviously every sector is failing. So I think we need a bit of a comm strategy about how we, just, so that people, because sometimes it can be really like unsure and to ask. But certainly I had a child who was registered in NHS Scotland, back and forth, and actually every time I raised something, I was told everything was fine, and unfortunately this child died. So and this was in Newham. So and the child was going to school and was accessing health services outside of a general practice. So I think we have to kind of move on from a general target. I think we need to know be able to benchmark ourselves amongst sort of our other agencies and stakeholders within Newham. So coming with a strategy like that, I think would be helpful too.
Absolutely, Samara. Thank you so much. I think this is the big concern nationally. There's a national decline. I mean, I have to mention that. So Coram Bath have delivered over the last 2 years, 2023 until this last year as well, a national-wide campaign for private fostering and the need for agencies to actually, because it is low everywhere. And in our area, obviously, it's particularly low from health, and which is I'm quite worried about, and we need to be sort of working together more. In terms of education, yes, absolutely, a lot of work has gone into the education department. I have actually embedded the private fostering triggers in the in-year application form, school form, so we are picking up a lot more children from the in-year school admission form and in the school admissions meeting. So that's a separate training that I deliver to the DSL for the secondary and primary schools, and that's obviously we're homing on quite a lot of that. Family hubs and on early years, and that's another area that I focus on as well in terms of nursery children who are attending. So a lot of work is actually being done at the moment outside of that. But yes, you're right. It's a joint effort to be able to sort of raising this notification. But yes, well, we're aware of, and I think there's a national recognition that the numbers are low. Nationally, so there is a greater need for how we as local authorities come together and jointly actually raise that awareness campaign, because it's very much on the agenda, and that these children need to be identified early on, and so that we can actually meaningfully intervene and assess their suitability and safeguard those children.
Okay.
Thank you, Tamara.
Laura?
Laura?
Hi there. Yeah, thanks, Nasima. I was just wondering, as GPs, if we make referrals to MASH, I had a example recently where we had a boy. I decided to register a boy, even though we didn't have a lot of details. We were told that his mum is in another country and she's entrusted this man to look after him. So I registered him as the safe thing to do, and wrote to MASH and said, we don't know anything that's going on in terms of legal guardianship or anything. Please, can you look into that? And all I got back was, okay, thank you for the referral. We've got some parenting classes that we're putting in place. So I had absolutely no idea who this man was, who's registered him, what the arrangements were. So I've had to write back to find out more details, which I haven't heard back yet. So I understand we might not need to know all the ins and outs, but I need to know more details than that.
Absolutely, you do. And if that would be really helpful, Laura, if you've got any named person that you've spoken to in MASH team, that would be really grateful. I can look that up. And
no problems.
And you can also pin me in an email. I've got my details are on the first slide. Please do pin me any details about that channel. I can certainly follow that up. I am the lead, so I have an oversight. I have an oversight of all the children who are known to the local authority. So from the point of MASH referral, from agencies where they refer in on the online portal, and it comes into the MASH team, I have, I know that notification's coming. So I do follow the journey of the child from that point. So I apologize if that child, you've been, sort of not given any helpful information, and please do pin me an email and I will follow that up for you.
Great.
Thank you. Will do. Thank you.
Thanks, Naseem, for sharing that info. And I think that was actually very insightful, that those figures that you shared at the start, very, very low. So I think that we will all continue to be more picking up these children and referring to you accordingly.
Absolutely.
Thanks for today.
Absolutely. So and I hope
we're running quite a bit behind.
Sure.
So if there's any other questions for Naseem, please do email her. Karen's kindly put her email address in the chat bar. So thanks, Naseem.
No worries. And I'm happy to attend any sort of GP, the practice safeguarding leads, just to have further conversation. I'm happy to do that. There is a poster that I've sent to Maggie that could be circulated, and it has all of our details. But I am also working on sending the guidance notes for GPs as well. That will be coming out shortly as well, and I'll forward that to Maggie.
Okay,
Emma.
brilliant.
Thank you so much. Thank you.
Okay, so now we're moving on to a Q&A session with Wax, who's our primary care rep. So Wax, and if you have any questions or comments for Wax, please do speak up.
Hi everyone. First, can you hear me okay?
Yes, we can hear you fine.
All right, brilliant. I hope everybody's okay. Sorry, I just hot-footing it from the care home. Since we last spoke, I believe it was 4 weeks ago. And sorry if any of this has already been picked up. I did join a little bit late. I think the biggest thing probably was the update around the BMA accepting the 25-26 contract. I don't know whether anybody's picked that up today, but I was just going to touch on a few key points. So in principle, and Tammy can correct me if I'm wrong, that the amendments to the 25-26 GMS contract have been proposed, accepted. What does that kind of mean for us? Well, I think they're floating a figure of about 7.2% cash growth in the contract, but there's some fine print and a bit more to understand around that, and most of that, and Tammy can correct me again, is it ended up in the Global Sun to pick up the rising costs of everything that we have to put on a day in, day out kind of basis. So premises, list growth, expenses, etc., and stuff like that. And my understanding also is that there's been some relaxation in some of the stuff for the primary care networks. And you would have heard about the R's kind of portfolio changing, which is welcomed. It gives us that flexibility, and I'm pretty sure that will support some of our practices where it's hard to find X role, etc., and stuff like that. There's also been an increase in the iOS, I believe, for the childhood vaccinations. Not much. It's just a childhood vaccination. It's not anything else. I personally, from my perspective, it's nowhere near enough. I've just come from a care home. One of the nurses was there doing some vaccination. Patients with really challenging kind of dementia, etc., and stuff like that. And she managed to do 5. Of course, she has to get there, then get back. There's the admin around it. There's the equipment and all of that. And I think that only picks up £50. Well, all of a sudden the costs aren't covered, isn't it? Tammy, that doesn't put you off. You still have to do all your care homes for the COVID vaccination. It's a labour of love. I don't think it's enough, and I think it should have been extended further than the childhood vaccinations. But my understanding is negotiations are still happening, and it might be something for the future. That's I think most of the points there. And then the other thing was, on the collective action, and again, LMC colleagues were on the call. My understanding here at the moment is that still things haven't changed. We know that we're still under pressure. We know that we need absolutely more support. I think that situation where we're still serving notices on various situations, I think absolutely needs to continue until things change. And Tammy's the master of this, and Lyra and that, and let me know. But just remember that we're all here to support you, and we all need to stick together. This Easter, around Ramadan time, end of financial year, it's been incredibly busy, right? And I'm pretty sure everybody's feeling it and stuff like that. So really well done. And I do hope over the Easter break you guys all get to have some Easter eggs, but also a couple of days where you can shut down. I don't know if Rima spoke earlier. Did Rima pick up anything earlier? Okay, so there was one update I wanted to give from the ICB Place perspective. Myself and Karen attended the Place meeting, and where we finished that kind of situation was we're being realistic around the future. We know that there's no money. I don't like talking about money. There is a lot of goodwill. It seems like transformation is really kind of halted, and that has been for some time. But I think there was agreement from everybody that each part of that system, that place system, local authority, community, mental health, voluntary care sector, patients, primary care, and the acutes will set aside 2 or 3 priorities, key kind of situations from the place perspective, relevant to their part of the kind of situation. And we've spoken about that stuff before from a primary care perspective. Mental health, it was around kind of ADHD, autism, and actually just the inpatient work. There were their 2 big ones. The place representatives of the hospital trust, it was more sort of around A&E and trying to get those waiting times down, but also do some work around a lot of residents who are frequently attending, they don't have a GP, but also no fixed abode. Primary care, very much about the enablers, estate, IT, quality of service, and supporting practices with access. And then with the local authority, they want to go really big on prevention. So each part of the system now, rather than have a long list of a million things that will never get done, and it's been there and it's just at the bottom of Dr. Sabir's pile of papers on his desk and etc., where things aren't happening, we need to really focus in on these areas. And from that primary care perspective, and I'm sure Sabir agrees, CQC are out in force. They're in B&D at the moment. I think Newham is next, so be ready. Access is a massive issue. We're hearing that all the time, despite layering on enhanced access, SDA, GP co-op, you name it, everything is there. But it's still a problem. We need support with that. So these are some of the must-dos in terms of priorities, but also don't touch as well. We need your support, ICB, but also don't touch what is already there. That's all I wanted to pick up. So not so much doom and gloom. Look ahead, new kind of contract kind of situation, maybe a year behind, but we've already started 25, looking forward to 26, 27. But that's okay. But happy to take any questions, and I know colleagues are on the call that will be able to support with some of the answers as well.
So Wax, Bapu's asked a question about the patient safety events service. Bapu, I don't know if you want to ask your question.
Thank you, Aparna. Sorry, my camera is not on. So this is a requirement for GP practice to contribute to the National Patient Learning Service, I think coming in September to us. So any idea how and why and all that? Max, thank you. If you don't know, don't worry.
This is Bapu, this is all about, oh, Tammy will come in as well, but my understanding is that this is all about sharing good learning and developing. And actually, Bapu, just imagine something happened in a PCN and it happened at one practice and then it wasn't shared and we didn't learn, and then it happened again in another practice. It could be like curtains, disaster kind of situation. There's lots of that kind of, it could be a safeguarding situation. It could be electrical, whatever, where patients are impacted. It could be a very challenging patient, etc., and stuff like that. This is all about learning. All of it's going to be anonymized, etc., and stuff like that. But actually, I think for developing our situation, developing our practices, I think it's actually a good thing. And I'll give you one good example that we're doing. We've come across some really, really challenging patients, really difficult behavior for some patients at the front desk or over the phone and stuff like that. So we're just doing some role plays, etc., and stuff like that to kind of support, etc., and stuff like that. But yeah, I think it's a good addition.
Sorry, so, Max, do we as practices need specific logins for this national portal, or do you know how it's going to be rolled out?
So Tammy's right. So we're waiting for the finer print, and it will be. But then, Bapu, I said this about the CQC portfolio, and then it was delayed for a year. So I don't want to tempt fate, but my understanding is that we're awaiting login information, template kind of situation. But personally, I think it will be a central email where we'll have to send a template to for now, because the logins kind of situation may be a bit challenging, but that's kind of what we're looking at. So keep some examples of stuff that happens around patient safety. It's good for your CQC. It's good for all staff development. And I think our frontline staff face so much challenges, whether they go to the care home or they're at the front desk, even when they're closing the building and going home. So we can only learn from these kind of situations to make it safe for everybody, patients and staff alike, to work in primary care.
Thank you, Max. Just
No
one
problem.
more. I mean,
Sure.
we just mentioned in passing about GP Corp. I missed that. What was that specifically? Can I just ask if you don't mind?
All the access that everybody's layering on, and we're still having challenges around access. And one of the must-dos is to continue the ICB to continue supporting access. So not pull SDA, not pull enhanced access, not mess around with funding, maybe do a little bit more development with SDA. So our patients really get seen rather than patients of 111, other boroughs, unregistered in Newham, etc., and all of that. We have to be a little bit hard about this because I don't know how many of my patients get seen in SDA. Okay, they might because they've been sent by the hospital, but certainly they weren't seen by me. And if you type in SDA into Google and NHS England, very much at the front of it, this is all about same day access for our GP patients, not patients that are being really at the moment ending up from other parts of the system. So we need some support with that. So it's a must do. The ICB supports that. And we're layering in lots of access, enhanced access, SDA, extra appointments, weekend appointments, flexible appointments and stuff like that. And that's what it referred to.
Thank you. Yeah, I think, I mean, obviously now with the SDA, ICB wants the PCNs to deliver it. It's come to a PCN level, and a couple of PCNs have chosen to go with the GP cooperative. But again, it's the same provider within the borough. And the process has been a bit rough riding with the ICB team not coordinating and things like that. But the idea is, like you said, for the patients to be seen at the right place at the right time, with the right intentions of colleagues as well, by hopefully a local GP who knows the local system and would see the patient or deal with the patient as the practice would deal with themselves as well. Thank you.
Yeah, it's not a cliche. Patients knows best. I totally agree. We should be thinking about the patient. Even when we have a here left or a right or a forward and a back here with our debates and our discussions and our agreements, we should say, okay, what does the patient want? And that will always give us the answer. And we need to make sure that we support that. But must do is support primary care access in Newham, in other boroughs, and don't take away the funding that we've already got from that. This is what we want to try and focus on, Bapu. We can't focus on everything. Like I said, long list. We can't do this. We can't do that. I understand that, but there's some absolute priority things that we want to be supported with from a primary care perspective.
100%. I agree with you completely. We also need to look at the 24/7 access as well. So I think
perhaps we have that discussion another time. Sorry, Wax.
No problem.
I'm sorry, because we're running behind everybody, and I appreciate those of you that have stayed on. Can I hand over to Tammy and Daniele for an LMC update? And Daniele, I think you were going to mention something anyway.
Yeah, I was just going to briefly ask Wax, if considering this approach for primary care, if the LMC could be involved maybe in some early engagement on some of these discussions.
Yeah, no, so I don't know. So there's been a change at the place team. So I believe Joe Fraser-Wise is carrying on, and Marie Ablechew is stepping down. You would have said the email, and from a place director perspective. But what we have said is that we have some very nice forums. We have the practice forum here today. We have the unified voice, and apologies, I couldn't get to that. The LMC meeting this week, and we have the LMC and the ICB meeting. We also have the meeting with CD. So these are our forums at the moment, where at least, at minimum, baseline, we should be discussing these things, and then identifying the various task and finish groups like we have with the enhanced services section out of that. But yeah, that's yeah, absolutely agree with you, Daniele, and I'll take it back to Rima and JFW to just pick up. But yeah, we're not going to be able to do this without doing this together.
Thanks.
Thanks, Tammy.
Yes, my voice may not hold out, so Daniele may have to pitch in. But I just wanted to pick up on Wax's point about the GP contract for 25-26. I think what's really important is to understand that we cannot be negotiating with the government if we're in dispute of the contract. So in a sense, we had to accept, having had a little bit of a negotiation, that that we were going to work with them, and that letter from letter was received from West Streeting literally the morning of our special conference on the 19th of March. So I think what's really important is to understand that nationally we will still be negotiating and really working closely with the government, and they seem to be willing from sort of a BMA GPC perspective to do that. But that doesn't mean that we have moved on from our local challenges. So our local collective corrective action needs to continue, and it's really important that we are basing that on the safe working guidance. Okay, and it is really important that we are demonstrating where those commissioning gaps are, not only for ourselves, in the benefits of our practices, but also for our patients. So if we think about the patient in the centre, there is no point in trying to fudge something if it's not sustainable and it's not safe. So what we're really trying to do is to move forward with that. But we appreciate that any of the uplifts that we are receiving, some of it's not new money, it's just repurposed. But the ideal is that it's more has gone into the core, but it doesn't restore the level of funding that we had previously. So we're still behind. So that's probably why, with all of the cost of living crisis, all of the national insurance contributions and national minimum wage, you will feel no different. It'll feel very tight. So it's very important as practices for us to remain financially viable, to be here for our patients, that you really do have to look at your individual bottom line. And as Alpana said, we haven't got a lot of time, so we haven't to go into all of the sort of changes with the contract, but I'm sure those will happen in the various fora to come. But just so that you understand from a BMA, GPC and LMC perspective, it is very important that we continue with our local issues and try and continue with that. Okay, right. So if we, Maggie, thank you so much for your indulgence with our slides. And I'm just going to apologise, I was not well, and I asked Daniele very late after our LMC meeting yesterday to just put these on because I didn't have headspace last week. So if we move on to the next slide, you know who I am and you know Daniele who I am. I think what's really important is that to understand that we've got elections in our LMC coming up. And what we really want to highlight is how important our work is. So it's not just about being, here to support practices, but it's about being a critical friend to the ICB, a supporter and champion for our patients, and also to make sure that we are asking for that transparency, clarity, and sort of real forward-thinking strategic planning that are aligned to our priorities within Newham. So we have 12 spaces on our current Newham LMC committee, and we've got seats available. And what we really want to do is to, sort of encourage you to look at, is being part of Newham LMC something that you would feel that you could support, that you could have some skills, critical thinking skills, whether it be analysis and liking spreadsheets like some of our members do, and really looking at the numbers in detail to support practices. But what we want you to appreciate is that it's, we can be really flexible. You can develop within the LMC, but also that you will improve your understanding of general practice. You can support your practices, you can support your PCNs, and you can support your patients. So really want to do a shout out for considering joining. Now, the ideal is that we would have an LMC rep in each of the PCNs, and I suppose my ask to practices and to CDs is to really encourage an invitation to your LMC rep, and if possible, please try and release that member of staff to go to those meetings so that you can get hands on the ground, put on the ground support, for issues. And it is a two-way street. You're telling us information, we're telling you, and we really value hearing from the coalface all of those issues so we can take it up at each level, so that we can look at challenging where needed. I appreciate sometimes it can seem like a little bit of a slow process because we go, and then it has to come down, it has to go out, and it's come in. But what's really important is that enables us to, one, really develop strong relationships, but it allows us to look at a problem from many different angles. And so it's really important to appreciate that whilst this is a GP sort of led forum, we do use lots of our other members of the team, so whether it be our practice managers, whether it be our nurses, and we can co-opt sort of people in to give us some support. And it's a really good opportunity for your GP trainees to also attend, and if you want to invite us to come to the VTS so that we can give this talk again, we're really happy to. But I think it's very important to understand that what we do at a Newham LMC level can really influence change at a national level, and that's what we're here for. Thank you. So some of our achievements, I think we've all kind of gone behind the bandwagon around sort of getting the maternity and midwife services to do some of their own prescribing, and that was a real success, and actually very proud of all of our Newham practices that sort of came together for that. But what's not on there is that actually, even with MAR charts, this is something that Newham has led across North East London, really active committee, getting that understanding about us not needing to do that piece of work with the MAR charts, that your prescription, your FP10 is enough of an instruction for that, and that will be a letter that's going out to Elfton. We'll be serving notice on that. But we've negotiated sort of additional payments for the vulnerable children scheme, and gone back and forth with lots and lots of different specs, whether it be for mental health, end of life, wound care, constant sort of negotiations in our Liz group. But for us, the important thing to continue is that local collective corrective action, and for us really to demonstrate the unfunded work that general practice is doing, so that we actually have time, we're freeing up time to focus on the long-term conditions and improving the health of our patients, but also sort of supporting the well-being of our clinicians and the viability of our Newham practices. So one of the things that I would like to just float, and I probably appreciate that we're running out of time, is next steps, corrective collective action, is to maybe look at how we are managing fit notes. So there is something to be said around fit notes, making sure that we are documenting the numbers that are being asked of us that should have been done at the hospital. The hospital don't have a way of monitoring that, but that's something that we could do in general practice by, sort of sending the template letters, informing the patients and signposting back. So that's one bit, not going to do any harm to the patient ultimately, but I think that's a conversation that we could have. And then secondly, that came up at special conference was around potentially putting not fit or maybe fit to work, but indefinitely. And so what that means is that if we are contracted to deliver 3 to 4 appointments per year, if you think about the number of appointments that you have to, review sick note requests or review those patients, when actually they may go back to work in 3 weeks or 10 weeks with their depression, or 3 weeks or 5 weeks with their back pain, that if we put indefinite, then that would shift the focus of that appointment to the employer, to DWP, to others in the system that may be able to support the patient, rather than it coming to only general practice. So I floated that idea at the UV meeting, and I'm really keen if I can get some feedback, and happy for you to do that on the GP WhatsApp group or contact me directly. So last slide, next steps for joining your LMC, because we have elections in June, and if you'd like to submit your nomination, it has to be in by the 3rd of June by 5 p.m. and you will get a copy of these slides. You can either go onto click on the link or use the QR code, but please do reach out to myself or any members of the committee and I forgot to put the slide in, Daniele, about who they all are, but basically we have Lyra, myself, Sadak, Jim, Anil, Annie, Alice. Who else am I missing? I've missed somebody. Did I say Sidor? Yeah, Sidor. Okay, so please do reach out and talk to us, and it's really important that you please consider presenting. Thank you. Oh, and just to say, all of you who are already on there, I am expecting you to also reapply. We need some continuity in our board. So new blood is good, but I also want us to retain a lot of our current members. Thank you, because I value all of you. Thanks.
Thank you. Thanks so much, Tammy. And thank you for pushing us to do all of this work where we're pushing things back. I had my first request from a midwife that I sent back. She emailed me back telling me that I was wrong. Then I emailed a friend and I said, I don't think I'm wrong in this. And the prescription was given by the hospital in the end. So I felt like I'd won a real battle then. So I'm going to continue to do that. And I've started looking at and sending back my shared care agreements. So I feel awful doing it, but I think it's the right thing to do.
Thank you, Aparna. I think that is it, isn't it? Generally, we're all really nice people, but actually it cannot survive. We cannot be safe and sustainable by just goodwill. It has to have a process. So yeah, well done.
Thanks. Right, so thank you for everybody for staying on. I know that I've not been good with my timekeeping, but I think it's because we had such great discussions today. I'm hoping everybody has a lovely Easter. As Wax said, try and switch off, take a break for a few days, enjoy some time with family and friends, and the sunshine if it's still there next week. So we've got our next forum next month, so look forward to seeing you all again then. Okay, take care everyone, bye.
Thanks so much.
Thanks,
bye all.
Bye everyone. Thanks Maggie.
Thanks
Maggie.
everyone.
Thanks Aparna.
You're welcome.
Thanks Tammy. Hope you feel better soon.
Cheers, guys. I'm going to scoot
It's
because
a
I've got a
week.
meeting with Subir, but it was a really good session
All right.
today.
Bye.
I thought it was
Thanks,
great.
Aparna.
Cheers,
Thank
guys.
you.
Bye.
And great sharing as usual, Aparna.
Oh,
Yeah.
thank you.
All right. Have a good week.
Not good with the timekeeping.
Do you know what?
There was a lot in it. There was a lot.
There's a lot, but it's, I think it's really important that some of the, that we need a discussion forum. And as much as not everybody is here, there's some really amazing things that come out of just getting together.
No, agree. And I still miss our Friday meetings in the hospital, because that's when we would ask each other, oh, I had a problem with this. What would you do? you know, it's not quite the same doing it online, but it's still good.
We make do, don't we? We make do. But it would be nice to kind of, even if we did once a quarter, to try and get together. I think we need to I think there is, you know, there's something to be said for that networking. And I don't think that, you know, people are able to necessarily have the confidence to say stuff online, whereas, you know, a little bit of a quiet question to somebody sitting next to you, you know, I'm not quite sure about this, what's going on, you know, you can do.
Yeah, Tabby, you're saying that. That's me. That's me that never used to speak. That's why, you know, when you mentioned that I am proud of myself that I'm able to chair a meeting like this, but I still find it very daunting. But I think I'm better at it than I was before.
All a learning curve. That's what we're here for. We need a bit of challenge and stimulation as human beings. So you're doing fine. Anyway, I'm going to go. My voice is like done for the afternoon.
Okay,
all right.
Take care.
Okay.
Enjoy.
Okay.
Bye-bye.
See
Thanks,
you.
Maggie. Bye.
Thank you. Aparna, so next month we're going to have it mental health.
Yeah, I think that's great. And then I think, could you just touch base with Imrana, because she will be very enthusiastic, and she'll be able to guide us in terms of the better speakers. So I think that what we should avoid is having the speakers that have already spoken in, for example, PLT, so that we're not duplicating.
Okay. All right. We'll do. Yeah. Okay. All right. Thank you.
Are you okay?
Yes. Not too bad. Not too bad. Glad the sun's shining. You okay?
Yeah, I'm okay. I'm worried. I got a message. I got an urgent screen message pop up during the meeting that one of my patients has got hemoglobin of 6. So now I'm thinking, oh, who am I going to refer her to? So I was thinking about that, but she's not reached the surgery yet.
Oh gosh. Okay.
So 60 is half of what it's supposed to be. So not good.
No.
But yeah.
Okay. All right. Take it easy. See you.
Bye.
Bye.